Welcome to the Waking Up Podcast. This is Sam Harris. I just have one more event to announce. We have a conference in New York in November that looks very interesting. And pre-sale tickets are available as of now to podcast subscribers. The conference is titled A Day of Reflection, and it will be November 17th at Lincoln Center in New York. And we are not shying away from controversy here. The first session is titled, Has Me Too Gone Too Far? And that will be a panel, I believe, moderated by the New York Times columnist Barry Weiss. And it'll have Masha Gessen and Claire Berlinski and Katie Roiphe. I believe Rebecca Traister is probably coming on board for that. Should be a great conversation about Me Too. And that will be followed by a panel titled, Can We Move Beyond Race? And that panel will contain Glenn Lowry and quite possibly Ta-Nehisi Coates. I don't believe he's confirmed yet, but I think he is all but confirmed. It'll also have Coleman Hughes, a young writer who's still an undergraduate at Columbia, but has been writing these quite impressive pieces on race for Quillette in recent weeks. I believe there are a few other people joining that panel as well. Then there will be a panel titled, Does Islam Pose a Unique Challenge to Modernity? And that will have Majid Nawaz and Ayaan Hirsi Ali and Fareed Zakaria and Douglas Murray, as well as the great Sarah Hayter. And I think Shadi Hamid, who's been on the podcast. And that will be, as you may be aware, hearing these names, each of these panels represents a wide range of opinion on these topics. These will be, I think, fairly thrilling conversations. Then I will be doing a meditation workshop that will be just me, and then I'll be taking your questions. And then the main event later in the evening is a panel titled, Is Reason Sacred? And I believe that will be me and Eric Weinstein and Brett Weinstein. I'm not sure who else is joining us there, but that will be moderated by Fareed Zakaria. So anyway, it should be a day of very interesting conversation. These tickets are currently only available to podcast supporters. Once again, the conference is November 17th. And now for today's podcast. Today I'm speaking with Dr. Nina Shapiro. Nina is a pediatric otolaryngologist. She's a pediatric ENT surgeon. And she's also a professor of head and neck surgery at UCLA. She's been featured in the New York Times, Time, the Wall Street Journal, NPR, CNN, and she's written a new book, the title of which is Hype, A Doctor's Guide to Medical Myths, Exaggerated Claims, and Bad Advice, How to Tell What's Real and What's Not. And Nina is just a fantastic doctor, so I wanted to have her on the podcast to give us an insider's view of medicine. I wanted to know what it's like to be a patient as a doctor. What should patients know that doctors know? So we spend most of the hour talking about that, but then we touch on her book a little bit at the end. Anyway, it was great to talk to Nina, and I hope you find this conversation useful. And now I bring you Nina Shapiro. I am here with Nina Shapiro. Nina, thanks for coming on the podcast.
Thanks for having me. Great to be here.
Unlike many of my guests, you are someone I know personally, and as a client, you're a fantastic doctor who has written a book that we'll be talking about. But so I just want to give that context because I can attest to the quality of your bedside manner and the quality of your friendship. So I've got a better view of you than most guests. Before we get into practical questions of health and your book, just remind me and tell our listeners about your background, because you were sort of born to be a doctor, if I'm not mistaken.
I guess so. Yeah, I do come from a medical family, and I don't have one of those really, really cool backstories about how I was first on Broadway and then ended up in medical school. I pretty much followed the track to medical school, all on the East Coast. Did my residency training and medical training back in Boston. Moved out to California for a year, and that was 22 years ago. And certainly kind of like arriving like Dorothy in Oz. I realized how nice it was out here, so I decided to stay. And I've been in academic medicine at UCLA for about 21 years now. And my specialty, which is really small and very narrow, is pediatric otolaryngology. So, pediatric ear, nose, and throat surgery. And I'm a professor at UCLA. So, I do some teaching and a lot of what we call tertiary or quaternary care medicine. So, sort of the referral cases that come from all over the country and actually all over the world to take care of, pretty sick kids.
So you did your medical degree at Harvard. Did you work anywhere else, or you went straight to UCLA?
So I did my medical school at Harvard and I did my residency at Harvard. And then I did a combined pediatric otolaryngology fellowship part of the year at Great Ormond Street Hospital in London, and then part of the year at Rady Children's Hospital in San Diego. And that's how I landed in California.
Did you go straight into working with kids, or did you work with adults for any significant period of time?
So my residency was a mix of kids and adults, and that's pretty standard for all otolaryngology residency. And then once I did my fellowship right after residency, I've been working with kids ever since then.
I'm always struck by how different the careers are depending on what type of doctor you decide to be. I mean, the overlap between being an ER doc and a dermatologist, as far as I can tell, is almost zero in terms of just what their life experience is like. So, where would you put your specialty in terms of the high stress side of things and the technically difficult side of things? You're a surgeon as well as someone who just actually diagnoses problems.
Right. So I sort of put my specialty, it's sort of like playing the piccolo in an orchestra where you do a lot of sort of regular day to day stuff, mundane. You don't really get noticed that much. Most of the stuff is pretty healthy people. And then every so often, there's this piercing, life threatening event that in a matter of seconds can go from great to horrific. So it's sort of and I do play the piccolo, so I feel like there's some connection there where, we for the most part we take care of healthy people and everybody smiles and it's pretty much an enjoyable time. But because I take care of tiny infants and we as a specialty are the last resort when it comes to an airway problem. So if somebody can't breathe and if that somebody happens to weigh 2 or 3 pounds, we're the ones that are called. So every so often we have this excruciating life-threatening moment and that just keeps us on our toes and we lose a little bit of sleep because of that.
Also, you're dealing with people's kids, which has to raise the stakes. I can tell you just from the side of being a parent that it definitely does. I'm way more stressed out dealing with the uncertainty around my kids' health than my own. So I can imagine you are seeing parents at their most stressed out where the news is seeming bad.
It is, yeah, and we joke that, the kids are the easy part, the parents are the hard part. Because, kids are actually for the most part a lot more resilient than adults and they're healthier than adults. But rightly so, parents are very, very stressed about anything related to their kids. And again, rightly so, but taking care of kids, we have a little bit of a different perspective because we know how much they can handle. Just a lot more than we can handle, that's for sure.
Yeah, well, so say more about that because I think a lot of the parental stress is predicated on not being in touch with that fact. When you've gone onto Google and read the fine print on whatever this scary diagnosis is, and you see all of the horrific possibilities, you sort of transfer that knowledge or pseudo knowledge. We'll talk about the problems with Google onto your kid. I think it just tacitly, where you're just assuming that this dark cloud hanging over your life now is casting the same amount of shade in your kid's mind, or at least could be. And of course, your kid, depending on the age, I mean, if your kid is in fact a kid, your kid knows nothing of these possibilities unless you tell them. And it's very likely that your concerns are out of proportion to the actual probabilities. And now, speaking of me and many of our listeners, you not being a doctor are not weighing these possibilities intelligently. And so, tell me a little more about how you perceive the experience of a child dealing with significant health adventures?
So, I hear a lot of concerns from parents, and some of these concerns are very, very well founded. For instance, if they're concerned about anesthesia or concerned about medications, there's a lot of solid information about that they can find. But, as you mentioned, Google, and that's what most people, doctors included, actually use when we're looking something up or, we're questioning something, is set to find the most extreme, most exaggerated information that it's devastating, and all it does for the most part is create some confusion and panic. And we love to panic. We love to sort of find the most extreme, whatever it is, certainly when it comes to our health or our child's health. And it will be easily found if you do a search. So, a lot of what I do day to day is calming people down and trying to put things into perspective. And what often people think about is the risk of an intervention, whether it's a medicine or a surgery, but few people are really thinking about the risk of not intervening. And they think of that always as less invasive, when oftentimes, and certainly in my practice, being less invasive or less proactive can actually be higher risk and more dangerous to a child. But a parent obviously just thinks of it as protecting their child from something, but that something could actually be much more beneficial than the risk of not doing something.
It is an interesting view of human health you get working only on kids because I think, as you say, kids are, for the most part, the healthiest people on earth. But obviously, there are the rarer cases where there's something very serious going wrong and the stakes are that much higher. Is there more to say about the resiliency of kids with respect to adults? I mean, in terms of just recuperating from procedures that work out or just most conditions being self-limiting. I mean, how do you think about the resiliency of a kid versus the resiliency of someone our age?
So, for the vast majority of kids, they are much more resilient than most adults. Their hearts are stronger, their lungs are stronger. When they have an infection, they recover more quickly. When they have any sort of surgery, they recover more quickly. And, it's astounding as as kids will go home the same day or the next day after a small heart surgery. You'd never see that in an adult. Kids have these devastating illnesses or a devastating event, and they bounce back. It's really, they are almost a different, obviously not a different species, but they're really a different type of being than adults. And because they seem so much more fragile and helpless, we rightly want to protect them more. But their resilience is so much better, stronger, and quicker than any adult's resilience, that we who take care of kids have sort of a different view on what they can tolerate, and it's a lot more than what most adults can tolerate.
Yeah, I once saw my daughter fall down the stairs from a distance. I mean, this is still I'm still horrified by this sight. I can't get. I still have PTSD, I think, from seeing this. And this was a fall that would have absolutely paralyzed a stuntman. I mean, this was just everything was wrong about this fall. It looked like her attempt to break her own neck, and she was completely fine.
Right.
So you sort of lose sight of that when you're being dragged through this labyrinth of medical uncertainty with your child.
And yeah, some of as kids, if you look at a little child, and we always say, oh, children are not just small adults. They're built to withstand stuff like that. Their necks are smaller, their heads are kind of puffier and more, kind of cushioned than ours are. So, a lot of, just physiologically and physically, kids are physically built to tolerate falls. They're babies. They're even like something as simple as a baby's vocal cords. What do babies do when they're not sleeping? They're crying, but they don't develop hoarseness or nodules or, vocal issues from crying for 10 hours per day because they're built to withstand that. So, it's some sort of evolutionary ability for kids to withstand a lot of the trauma that we as adults, if we fell down the stairs, we'd crack our necks or break our skulls. But kids, literally, we say they bounce. And and it's great. That's why they can go on to adulthood and then get hurt.
Yeah, yeah. Well, I want your doctor's eye view of being a patient, essentially, or the parent of a child who's a patient. And I want to know how you go through these experiences of getting sick or having people in your life get sick, and just how it is you would navigate a hospital, and how you think about second opinions and all of that. We've touched a couple of these issues already. You get a diagnosis that sounds scary from one doctor. You go home and Google it and get properly terrified by the what is in many cases a very low probability risk. And then it's certainly standard procedure to get a second opinion. Certainly if there's any significant intervention on the menu, like a surgery. At this point, I have gone down this path enough that all this is anecdotal, obviously, but if judging from my experience, both when I'm the patient and when my kids have been, it's fairly alarming how often I've gotten a false diagnosis, that is overturned by a second opinion. And in some cases, the first diagnosis came with a very strong recommendation for treatment that was a significant intervention. I once left a doctor's office where, I forget, this is now 10, 15 years ago, I was having some problem. I think I had pain in my hands or something. I was a martial artist. There were plausible reasons why I might have pain in my hands, but I wound up in the care of a rheumatologist who diagnosed me with, I think it was psoriatic arthritis, and sent me out of the office with a month's supply of methotrexate and Humira, which are significant medications, and basically was, putting me on these drugs for the rest of my life. And, it seemed quite crazy at the time, and I went and got a second opinion, and another rheumatologist said, "Well, you don't have psoriatic arthritis. You probably just did something to your hands." But that kind of thing has happened with my daughters. It's fairly startling. And in fact, I met you in this context, or at least I met you professionally in this context, where I think my daughter had been diagnosed with a cholesteatoma by a pediatrician, and this is very much in your wheelhouse. I had never even heard of a cholesteatoma, and I brought her into you, and you took one look in her ear and said, "Well, she doesn't have a cholesteatoma." But I had spent 24 hours previously having Googled a cholesteatoma and realized how much I didn't want her to have one, and it was a fairly stressful day. So, how do you think about second opinions, and what advice do you have for people? Because doctors obviously can quite confidently represent some state of affairs that isn't true.
Yeah, second opinions are, surprisingly a luxury. A lot of people don't have the wherewithal or the means to obtain second opinions, unfortunately. So a lot of people, just are lucky and feel lucky that they can just get in to see a doctor. And unfortunately, a lot of people are misdiagnosed or, receiving overly aggressive or underly aggressive treatment. And this is a big problem. As you've had the experience with your daughter, I see patients and sometimes they're a bit disappointed when I say, nope, there's not the problem and your child doesn't need surgery. And the family actually leaves a little bit frustrated because they almost wanted there to be something. And I tell them, you will find a surgeon who will operate on your child, guaranteed. So it is a problem, and there isn't really the why this is happening, why people in different medical centers recommend different treatments unless it's something that's has several pathways. For instance, if you have a cancer patient, there are several different ways to approach it, whether it's surgery, chemotherapy, surgery, chemoradiation. There are some variations to those sorts of paths, and a lot of that depends on the medical status of the patient, how healthy they are, their age, what they can tolerate. But this sort of stuff where somebody doesn't have something and then they end up getting a surgery, that is not good medical care, unfortunately. I think, if you have a new problem and you have the wherewithal to obtain two or even three opinions and it's not something urgent, I think I do encourage people to do that. And for the most part, you will find, for instance, if it's a surgical issue and you see two surgeons, you may find some minor variations in how they do the surgery or exactly what type of surgery, but if one surgeon says operate and the other surgeon says absolutely don't operate, then you need a third opinion to sort
Mm.
of break the tie. But, it's a problem.
What about bias built into the disciplines? I mean, so for, surgeons have the tool of surgery, and I think it's a common concern and maybe a valid one that if you go to a surgeon for advice, really his or her choice will always be, well, to operate or not. And that could bias you in the direction of getting surgery that perhaps you don't need. I mean, I guess this is somewhat linked to the question of whether or not to get certain kinds of tests. Like I remember once, again, this is back to my own personal martial arts generated problems, but I was having some back pain and I asked my doctor whether he thought I should get an MRI of my back. And he said, well, you're whatever it was at the time, 40 years old. I can guarantee you have at least one bulging disc. You'd be a miracle not to have something that we can image there. And seeing it in your scan is not going to tell you whether it really is the source of your symptoms. And then you are going to want to have a conversation with a surgeon, and you will find one who will say, "Yeah, we could shave that off for you," or "This is something that we can talk about." And why start that process at all when what I'm going to recommend you do, whatever we see on that film, is do physical therapy, back off the martial arts, and avoid surgery at almost any cost for a problem of this scale. There's this problem of too much information, and maybe there's this problem of talking to the wrong specialty too early.
Well, hopefully not. I like to tell people that that their child doesn't need surgery. And I think, we have to sort of wonder, where if it's that much of a concern, if people are feeling that you can't go to a surgeon for an evaluation because they are a hammer and they're just looking for a nail, that says that's a pretty negative feeling or, concern about medicine in general, that if you go to a certain specialty, they will find a problem related to their specialty. And I think that's what's created a lot of, sort of mistrust of medicine, and rightly so, because people are, known to overoperate. As you said, you have a small disc problem that could probably be remedied just by taking, some physical therapy or resting or doing different exercises, as opposed to, oh, you have a disc bulge, we need to operate on it. And, unfortunately, there are a lot of doctors out there, a lot of surgeons out there who are sort of cutting, recklessly or unnecessarily, and, with the same result as not doing surgery. But, it's unfortunate that that's how it's become, that people feel that if they go to a rheumatologist, you're going to leave the office with a rheumatologic disease, or if you go to a spine surgeon, you're going to leave, scheduled for spine surgery. And, I think I don't know how to sort of purify medicine, or how we can sort of get back to, well, if you go to a surgeon and the surgeon tells you you don't need surgery, actually, some people are disappointed with that recommendation and they'll go find someone else who will recommend surgery. But I think if there is something so drastic that's recommended, then you do need to get a second or a third opinion.
Does this all just fall into the bin of there being a normal distribution in the talent and knowledge and ethics and any other relevant variable among doctors as there is in almost anything else? I mean, I think this is something that people don't realize or don't want to realize because there's not really a good or obvious remedy for it. But I mean, we recognize that there's a normal distribution of ability in any domain. I mean, baseball players aren't all the same skill level, and you could extend this to every profession. But I think we all want to assume that doctors are all at the same level or that the differences between them don't matter. How do you, as a doctor, think about that? I mean, when a friend of yours has to get a surgery and is asking you, how to find a good surgeon, is there a kind of insider knowledge of there being good surgeons and bad surgeons in medicine, or do the bad surgeons magically disappear?
Uh, bad surgeons never disappear, unfortunately. I think there is a little bit of an insider track that we in medicine are privy to. Certainly if you work in a large medical center, We sort of know certainly how to navigate this very complex system internally and then even around the country. For instance, if I get a call from a friend across the country and their child or they need a surgery or have a specific medical problem, it's one of those almost like the 6 degrees of separation, but it's usually only 2 or 3 degrees. Within a phone call or two, I could find them the right person that is trustworthy, has a good background, has good ethics, as you said, and is not just operating because they feel everybody needs a certain type of surgery. So, and there is, just as with most fields, there is a little bit of an insider track. And one of the benefits of being in medicine is that we have pretty good access to other specialists pretty quickly.
All right, so we'll give your phone number at the end of this podcast, and you'll just get a few calls a day for medical referrals.
Just my home address would
Yeah.
be good. Yeah.
So this just brings me to my wanting your doctor's eye view of getting pushed or dragged into the machine of medical attention. And so you're sick or someone close to you is sick and you now have to go to the hospital. What do you, as a physician, know about checking into a hospital that the average patient might not? What are your concerns? What do you want to avoid at all costs? What kind of questions do you ask that might not occur to the average person to ask? How do you navigate a hospital?
So that really depends on whether it's something that's planned, a scheduled procedure or a scheduled admission or surgery versus an emergency situation. Obviously, if there's an emergency situation and it's something in my home hospital, whether it's as when I was a resident in across the country or now here in Los Angeles, we do have, there is a little bit of professional courtesy, just as with if you're in any other line of work, you will get a little bit of professional courtesy and perhaps get in the door a little more quickly, get seen by who you want to get seen a little more quickly. But what I've found, and, certainly living and working in Los Angeles, where we have a very substantial VIP population, as we say, everybody's a VIP. But we have VIPs. They often try to create and navigate their own treatment plan. And it ends up being creating the worst possible medical care. They may ask for somebody who they think is the best anesthesiologist, for instance, but because the person has a high administrative title, but they have no experience with their family member's medical condition, it may be the absolute wrong person. People also have this notion that they want to be the first procedure of the day, for a surgeon's busy schedule. Well, that's not always necessarily the best time to have surgery. Or I don't want any, if you're in a teaching hospital, I don't want any residents or medical students around. Well, if we're used to a certain way of practicing and then somebody tries to change that routine because they think they'll get better care, it actually just makes for more anxiety on the part of the caregivers and can create actually a worse care situation. So oftentimes, it's best to just go with the flow of a hospital because they know what they do best. They know their routines, how they do them best. And sometimes trying to alter that, even if we as doctors try to alter the routine of the caregivers, it can actually backfire and get in the way. So, a lot of hospitals, especially the big ones, are very frustrating. They feel very inefficient, but a lot of that is just the nature of how they work, and the care ends up being better sometimes by not making a big stink about who you are and who you know, and trying to sort of cut corners.
Has this been quantified in any way? It's hard to see how it would be quantified, but I'm sure there are some famous cases where some, Hollywood celebrity got what was obviously substandard care because the whole machine of the hospital was thrown into disequilibrium by all of his or her demands and all of the star fuckery going on. Is that what you're thinking of when you talk about this?
Yeah, I mean, certainly there've been some extreme cases. It was, there was one of the babies at one of the hospitals in Los Angeles, received a thousand times the amount of a certain medication, and had a life-threatening bleed, and that was a movie star's kid, and even if they weren't getting treated differently by a different team, everybody sort of has a little more anxiety when it's a movie star, or a politician, or a well-known person. Just it's human nature to feel a little more anxious because of that. And we all feel, we all take care of these well-known people, and the ones who sort of go with the flow. Again, no major tragedies that I know of have happened, certainly in my experience, but I feel better almost when I don't know who they are in advance, as opposed to knowing, oh, this famous person is coming in and we have to do this, and create a whole new sort of scenario because they are who they are, as opposed to just doing what we do. But there have been cases, I mean, they've been in the news about stars having these tragedies, and it's hard to know if it was because they were who they were, or it just happened to be newsworthy because they're famous.
Well, so you touched on one point, which is a bit of a pet peeve of mine based on some personal experience. So the issue of going into a teaching hospital, my default demand in those situations is, I don't want anyone learning a procedure that carries any significant risk on me or my children. And, I'm totally in touch with the paradox here of the ethics of pedagogy. I mean, people have to learn how to do these procedures. I want them to learn it. I just don't want them to learn it on me or my daughters. It's defensible in the moment because it's just she gets one chance to receive this intubation or whatever it is, and I want somebody who's an expert doing it. What's your sense? I know you have to play both sides of this, but what's your sense of the reasonableness of that demand?
Oh, I think it's a very reasonable demand. And I think that more now than ever, residents, interns, medical students actually have less autonomy than they did years ago. It's not, the notion of, the anesthesiologist is, out playing golf or in the cafeteria while your family members, undergoing anesthesia is certainly no longer the case. Usually if a resident or a medical student is involved in a case, it's usually as an assistant. So, that autonomy is becoming less and less of an issue and a concern for, for patients when they're going to a teaching hospital. The negative side is that I think because resident hours are restricted and they work fewer hours per week and they take less overnight call, I'm curious to see in a generation or two what sort of doctors we have, because they are getting a lot less experience during their residency training and a lot less hands-on than I did, that's for sure.
But there has to be a first time where someone is actually flying the ship him or herself. There's a first time you're the one performing, that part of the surgery or any specific intervention that runs a risk of going wrong. I can imagine you can ride shotgun on that as many times as you like, but at a certain point, you're holding the knife for the first time. I mean, there's no way to make it any more incremental than that, is there?
There is actually. I mean, there's so many for instance, an intubation, for instance, is not just, it's not like watching ER where they're, oh, I'm in, it's there's several steps to it. So, a lot of times in a residency training, it's a gradual rise to doing something. Or if you're assisting in a, let's say it's a liver transplant, there, an 8-hour surgery, there's so many parts to it. The skin incision is the smallest part, but people think of that as, oh, the knife, but you're not, cutting through the liver with the skin incision. So, there is sort of a gradual rise to what you do, certainly in a surgical field or an anesthesia field. It's not just all or nothing.
And so how has training changed in recent years? I've heard rumors that residents are now no longer as sleep deprived as they used to be. That to the layperson's ear sounds like a wholly good thing, except I just heard you worry that maybe we're not producing a generation of doctors that are as pressure tested as your generation is. Just give me a picture of how training has changed in recent years.
Yeah, training has changed remarkably. It started with the Libby Zion case in the 80s, where, a college girl came into an emergency room in New York and she received a medication that interfered with her daily medication and she died. And the claim was that this was due to the residents, one, sleep deprivation, and two, not being supervised. But primarily it was the issue of sleep deprivation. And ever since that case became an issue, residency work hours have been restricted to, 60 to 80 hours per week. And also within that, you have a limited amount of number of hours in a row that you can be working. So yes, for the most part, this is great, and it makes for much happier residents, much more balanced residents, residents who will likely stay in medicine because they have a balanced life. I mean, the word residency would literally mean that you would be a resident of a hospital and you would pretty much live there. And, those of us who trained before these restrictions, we do feel that, we worked over 100 hours per week and we would stay in the hospital for 2 or 3 days at a time. And, we would sort of joke that the only bad thing about being on call every other night is that you miss half the cases. So, it's just a different mentality of, what that certainly when it comes to surgeons, that we're sort of tough and we could work hard and, we're invincible, but it's not a human way to be. And the early studies looking at the metrics of whether this is really beneficial have shown that there's some improvements in, the question is really, are fewer mistakes being made? That's really what the outcome is going to be. Fewer medical errors, better patient outcomes. And, the studies have been mixed as far as, whether that's really the case because there's so much less continuity of care. So even if it's a tired resident, you're still taking care of the same patient and you're not passing the baton every 6 or 8 hours. So, it's a little bit of a mixed bag.
And what about the augmentation of doctors' abilities or degradation based on access to information? We've got doctors or residents who jump on their smartphones to aid in a diagnosis. It used to be that no one had a smartphone and presumably, you had to have more facts in your head, although obviously there were fewer facts to be known. How do you view the use of technology here? Is it all to the good or is it undermining people's abilities in any respect?
Well, for the most part, it's good. And because most people who are working in medicine know how to navigate technology and find valid articles or useful pieces of information. But the problem is, we would have to go to the library and figure out what to search. And maybe if we had a computer, we can put in some search terms. But what people have lost is the thinking ability to figure out how to find what they're looking for, or how to sort of investigate it as opposed to just pushing a few buttons on your smartphone with a keyword and you'll dig around and the information will sort of come to you. So it's a little bit of a sponge effect as opposed to a shark where you're actually going to look for the information and figure out how to find the information because you have a smartphone or a tablet that you're walking around with. It takes out a little bit of the effort to get the information, but you can get it very quickly.
Is AI yet making any inroads into your experience as a doctor? I had thought that like IBM Watson has a medical product where it's not just a matter of a human brain searching a database, but it's significantly facilitated by some form of narrow AI. Is that showing up yet or not?
Not quite yet in the mainstream. I mean, certainly we talk about it and heard about it. I think we're more still at the level of robotics, which is a little bit of, it's not really AI, but it's a little bit of artificial function. We don't touch the patient anymore. A lot of the time when we're doing surgery, it's a robot who's doing the surgery and we're sitting across the room. So, I think there's certainly some, I guess the A part is definitely part of medicine, but the AI not quite yet in the mainstream.
So, what percentage of your surgeries are done with a robot?
Actually, mine are not. A lot of head and neck surgeries are though. So a lot of surgeries in my department, I'd say probably 15, 20% are done with a robot.
And is that a totally different skill set manually? I mean, is that just you have to learn how to pilot a robot as opposed to actually work on a human body?
Yeah, so it's an extra training. Sometimes it's a full year of fellowship or several, extra training courses depending on where you are in your career to learn how to work the robot. It's pretty amazing. It's pretty cool to see. It is literally, like, feels like rocket science because the robot arms can get to areas that human instruments, human fingers with instruments can't get to. So, it's a revolutionary technique. It's in its infancy. Certainly, it's not perfect yet, but it has really improved patient outcomes because you can do these tiny little surgeries without being so aggressive and get the same outcome.
Mm. And is this one of these things where most hospitals would not have this resource, and it's the difference between being in a big city hospital like UCLA and being elsewhere?
Yes, it's at this point limited to large academic centers or large, medical centers in cities because it's a pretty specialized device.
So take me back to you in the hospital, let's say caring for a loved one, and let's not make it UCLA. So you're just in through dint of bad luck, you and your family are in some other city and someone has to be hospitalized. How do you think about risk mitigation from the side of being a patient? Is there anything you think you do differently or questions that you ask that most people wouldn't know to ask because they haven't seen the other side of medicine?
Oh, absolutely. I mean, we're a two surgeon family. So, we can't help ourselves by, sort of becoming involved in whatever our family member is going through. So it's sort of, we're stuck with that information. So clearly we're going to have bias and clearly we're going to, question the doctors differently and question the medical care. But we try, we have been in this situation. I have been traveling with my family where a family member has needed urgent hospitalization in the middle of what we thought was the middle of nowhere. It seemed like the middle of nowhere. It was very beautiful, but it was, up in the mountains in Northern California. And it was the question was, and we were faced with this. We were in this very small, lovely hospital with very little care. And the question was whether we should take the risk of driving 7 hours home with a critically ill child, or whether we should sort of tough it out and stay in this very rural hospital. And we rightly decided to stay. And we ended up getting very good care. And I think it's hard as a doctor, and it's hard as a doctor working in a tertiary medical center to give some trust to people outside of your sort of known area. But we did end up just taking a step back and being the patient and being the patient family, and everything worked out. I think if you travel around the world as a family, you can't have everything at your fingertips at all times, and you do have to sort of relinquish some control in those situations.
What would you do differently than a naive patient would? Like, you're in a hospital, it's a big city hospital, it's just not your hospital, you don't know anyone personally in the hospital, and you're now in dialogue with a doctor who is dealing with the medical emergency around your son. What are you asking the doctor that I won't think to ask?
That's a great question. It's really hard not to just sort of participate in the decision making when, especially if it's a family member. I think I would probably just ask more specific questions about a particular medical issue, just because even though I have a narrow subspecialty, we're all doctors, we have some basic medical knowledge. So I would probably be asking different questions than, someone who's not medical, just as when I take care of doctors' kids or surgeon, and or surgeons' kids, they're going to be asking me different questions than someone who's not in medicine. And it's just the nature of it. And it's a little bit of a club. So we have, this quiet understanding amongst ourselves that they know that I know, and so there's a little bit of, it's almost like a little bit of a club that they know that I'm going to know some medicine, and they're going to have to be, speak to me a little bit differently than if it was someone who was non-medical.
Does it come down to things like, just to take surgery as an example, like if you're in a big city hospital, is it acknowledged that there's a range of abilities and outcomes, the statistics associated with each subspecialty, with each surgeon or each anesthesiologist? Is it coherent to say something like, and would you say something like, I want you to give me your best anesthesiologist? Would it be acknowledged that there's a best anesthesiologist, or would it be just guaranteed that everyone would be thinking and saying, "Well, all of our anesthesiologists are good"?
I think the latter actually, and I get that question all the time. Is there, I want your top anesthesiologist or I want your best team. And there is no, there are a lot of really good ones. And what I tell people is I only work with people I want to work with. And I have the luxury to do that. And I think that, people get sort of wrapped up in, oh, I want the chair, or I want the most senior person or the most experienced. That's not always in your best interest. I think that you want somebody good. You want somebody to do a good job. And I think if I were, with my family member and at a hospital and it was a surgical situation or even a medical situation, I would just want people who are good and and not necessarily I want the best. I think people there is no best, there is no worst. And a lot of those choices are out of our control. And I think when you start to do that, and again, we talked about how in Los Angeles people try to create their OR team because they're VIPs and they think they can create this best team that's when care gets sort of declined. And I actually try not to do that. If I was in the situation in and out, across the country in a city hospital where I didn't know anybody, I wouldn't demand the best or, the top or the most senior, because those may not necessarily be the right group at the time.
Mm. Well, yeah, because you might be just dragging someone in who's in the sort of fundraising period of his or her career and is actually not the best, even though they're the chair or whatever. But we've already acknowledged that there's a range of abilities among surgeons and presumably every other discipline. So, if there are bad surgeons out there, presumably you don't want to get one. So, what would you do to avoid getting a bad surgeon or any other specialist who's not as good as you want?
Well, again, it depends on this. If it's an emergency situation, unfortunately, you get what you get and you don't get upset. But if it's somewhat more elective, again, even though, if we're in the strange place, we can always make a few phone calls and find out, kind of the inside scoop a little bit. But I think for someone who's not in medicine and can't do that, you can. I'm always reluctant to look at those online reviews of doctors. People, Yelp and all those other systems are extremely inaccurate. I think even just asking around, your hospital team, you can usually find out. The nurses are usually the best judges of doctors, so they'll often tell you whether you have a good surgeon or not.
Are there good, unbiased sources of information with respect to outcomes? So if you need heart surgery and there are 2 big hospitals in your city, is it easy to get the outcome measures for that specific surgery in those 2 hospitals?
There are some metrics. There's something called the Leapfrog Group, which looks at larger hospital outcomes. And, for instance, if it's a heart surgery or, a major, major surgery that you're considering for you or your family member, you can get the outcomes for hospitals and for individual surgeons. But, even with that, there's always going to be a little bit of, internal bias. For instance, oh, were they taking care of more complicated patients? And that's why they had higher risks and more complications because they were taking care of, the sickest of the sick as opposed to the healthy patients that just come in off the street for their first surgery. So, it's hard to obtain a lot of this sort of pure data on surgical outcomes because there's so much more involved because these are patients with other sort of issues going on.
Yeah, I mean, at UCLA, you've got people being flown in by helicopter to deal with something that the other hospital couldn't deal with. Okay, so I've spent a lot of time talking to you about everything that's not in your book because I wanted to get your view of all this, and this is fine because our conversation will not exhaust the interest in your book, and people will just have to read it. But let's pivot now to your book and what you think people should know about how to maintain their health and the health of their families. Your book is Hype, A Doctor's Guide to Medical Myths, Exaggerated Claims, and Bad Advice, and How to Tell What's Real and What's Not. And you go through all of these areas, I mean, some of which we've touched, but many which we haven't, like diet and alternative medicine, vitamins, the kinds of things that people should reach for as remedies or do reach for as remedies in ways that may be ill considered, and the kinds of perception of risk that guide these decisions, which aren't really, at the end of the day, all that rational. So, if you could give in 5 minutes advice for a member of our species in the year 2018 with respect to how a person should think about staying healthy, what are the first things you would say?
Well, I think one of the one of the main inspirations for writing the book was that I was hearing, whether it was at work or socially or family, outside families, my inspiration was that there were so many people who were misguided on the ideas of what is healthy. It's such a basic idea that I would come home from work or come home from, a school drop off, and my head would be spinning, wondering where are people getting this information, and did I miss something? What's good for you, what's risky, what's harmful, what's toxic, what's contaminated, all these buzzwords going around. So, the goal was really to help people relax. And we're all, we all worry. We're all concerned about our health, our family's health, the health of this planet, the health of our species. And we are grasping at all of these extreme measures to obtain this so-called perfect health or adequate health, that we've lost sight of the basics. And risk is one of the biggies, and I have a whole chapter on risk, because people have this kind of bizarre notion of what's risky for their health or what's risky for their families, and they're completely missing the boat on what's really risky and what's really healthy. So, I think that the goal of the book was to put people's minds at ease a little bit, and also put some perspective into what we're so worried about, what we're so focused on, and but lost focus on what really matters and what's really basic to keep ourselves alive and healthy. I mean, what do we want? We want to live long, we want our families to live long, and we want to live well. We want to have healthy living, not just a long number of years. It doesn't matter if we live to 95 if we are in a vegetative state for the last 15 years of our lives. We want to live healthy lives, and long. That's the other issue, is how many years, what's the magic number of years we want to live. So, they're very simple things we need to do, not necessarily, and it doesn't necessarily involve a juice cleanse or a detox or an extreme diet or, all of these, kind of to me, crazy notions of, how to keep ourselves healthy.
Hmm. What are the primary pieces of advice you would give? I'll start you off with don't smoke cigarettes, and if you're smoking, quit.
Don't smoke cigarettes, quit smoking. And then, just briefly about smoking, so what was created to help people stop smoking? It was first, nicotine patches, nicotine gum, and then vaping. And now vaping has become the gateway for kids to start smoking. So, that's sort of turned 180 degrees to the negative, where electronic cigarettes were supposed to be used to help people quit smoking. And now it's used in middle schools. Juuling is the new term, apparently, to get kids to start smoking because it tastes like candy. So, obviously, to stop smoking, basic stuff. If you bike, wear a bicycle helmet. That, people die biking just from not wearing a helmet. If you're out in the sun, wear sunscreen. People die from skin cancer every day. If you're in a car, wear a seatbelt. And these, they seem so obvious, but this is how people don't survive. If you have a phone, don't text and drive. If you have a teenager who's learning to drive, make sure they know they cannot text and drive. This is how people die in car accidents. They're not dying from Ebola infections, they're dying from texting and driving. So these are very basic things that, everyone can say, "Oh, yes, yes, of course not," but we all do it. We all put our lives in danger every day. If we live in a big city, even if we live in a small town, we all drive. We put our kids in the car. We have our phones going off. We have so much distraction, and this is, just pure boring numbers wise, this is how people don't survive.
I want to linger on texting and driving for a second because I'm sure this is true of a significant percentage of our audience that there's a range of concerns that they have with respect to how to mitigate risk. And, they might be afraid to fly. They might be afraid of catching esoteric illnesses when they hit the news, but they don't feel any fear when reaching for their phone and texting while driving or texting while walking as a pedestrian, crossing the street, which you see more and more. And if that's you, there's such a mismatch between the actual risk you're incurring with what you do casually and what you're spending your time worrying about. It's just there's no reason to worry about anything if you're still texting while driving. That's the first thing you need to worry about. And I recently heard on the radio that the incidence of pedestrians being killed had doubled in a big city where I was listening to this. And the reasons proffered for this never referenced a smartphone. And they were saying, well, maybe there are just more pedestrians now. People are out walking more. But from the side of one who now is scrupulous about not texting while driving, but, I certainly had my moments once we were first getting these phones in hand. It strikes me as absolutely obvious what would be killing pedestrians in greater numbers now, because the moment which is most tempting to text is the moment when you're at a red light and you just decide to check your phone, and that checking of the phone begins to extend past the point where you're now the light's green and you're moving, but you're still going slow enough that you imagine you can tolerate a few more seconds of phone interaction. And so it is with the pedestrians that you see people crossing the street all the time, never looking at anything but their phones. You've got inattention on both sides of this, and it's nuts. I don't know what the numbers are, but I'm sure we're talking about thousands of people every year who are being killed or injured by this one use case. I don't know if you are on the side of, I'm sure ER docs see this all the time, but it is a very strange situation we're in where we're quite obviously worried about the wrong things.
Yeah. I mean, I think exactly what you said. And I think it's this notion of control that, oh, I can do it. I'm a great driver. Or I cross the street all the time. I'm in control of my phone. I'm pushing the buttons. And so people feel that there's less risk if they're doing the action as opposed to something being foisted on them like a virus or, some crazy infection on an airplane. They feel that it's somewhat safer, which is completely erroneous.
Okay, so what other actionable advice do you have here? What about with respect to diet? Diet is obviously an area where people, I think for understandable reasons, live with significant uncertainty. I've said this somewhere before. I consider it one of the greatest embarrassments of modern science that there's any diversity of opinion at all about what human beings should eat so as to be healthy. I mean, how is it that we still don't have a rock solid consensus on what is a healthy diet? And not only do we not have a consensus, you can have seemingly scientifically trained people recommend the opposite diets. I mean, you can get just the eat as much saturated fat as you possibly can diet to whatever you do, cut out saturated fat. And as far as I can tell, the only thing that you can get everyone to agree on is that cutting down sugar is virtually always a good idea. There's no one who will say, by all means, eat as much sugar as you can. But that's where total lack of controversy stops. So, I mean, do you have a sense of what people should be eating so as to idiot proof their diets?
Well, I think it's people love they can talk about their diets endlessly and vary what diet they're on endlessly. And just what your point about sugar is kind of interesting, because yes, you should, it's common sense and common knowledge to limit your sugar. But sugar has become vilified to the point where people think that sugar is causing cancer, which, you certainly, it can be associated with some cancers, but then people twist that to say, I'm going to cut out sugar and that's going to cure my cancer. And sugar is feeding my cancer cells. So if I don't eat sugar in my diet, my cancer will go away, which is complete nonsense and, deadly, obviously. I think for diets, again, my head is spinning when I hear about the newest, it used to be called Atkins, now it's called keto, and then there's paleo and gluten free and, sugar free, and I'm cutting this and I'm cutting that. And the boring idea of moderation, which seems so uninteresting, and you're not going to, write a book about have a moderate diet and eat a little bit of everything and, eat until you're full. And eating should not be something that you're doing from a pouch because we have teeth. That, it's become this overwhelming, whether it's a fad or a trend that comes and goes, it is complete utter nonsense in my in my view. I think that, this notion of foods having more power than they actually do has created this society of, we're so focused on food, and people can spend their days, talking about their diet and focusing on their diet, and, it certainly gives people something to do, but it's a complete waste of time and energy, and it doesn't necessarily make somebody healthier. I think people sort of jump the gun by saying, if you eat this certain food, it's going to do this certain thing to my body. And it's not that simple. We have a pretty complex system going on inside of our bodies that if you eat a superfood, it's not going to make you a superhuman person.
So yeah, certain foods have been fetishized. I think I noticed recently that kale, which was, probably this decade's most remarked superfood, now has some downside. I think there's been some report on if you're replacing all salad with kale, you're probably getting too much of some toxin. The other shoe is continually dropping on many of these recommendations, but it is slightly alarming that and again, this is just anecdotal information, when getting advice from medical authorities, let's say a cardiologist, you can get nutritional advice that seems starkly antiquated. Was recently talking to a cardiologist who recommended that I eat less cholesterol. And as far as I know, I mean, there's basically no nutrition scientist now who thinks that dietary cholesterol is what moves the needle in terms of a person's lipid profile and risk for heart disease. I don't know if that is still a controversial point, but being outside of medicine and just consuming more of what one reads from people who are spending all their time focused on the nutrition science side of it, that's just a kind of a crazy 20 or 30-year-old recommendation. And yet I've had a cardiologist give it to me in the last 3 months. Is there a way in which it's reasonable to worry that medicine isn't necessarily up to speed on all of these questions?
Well, yeah, I think some of it is, oh, how would you be a cardiologist and not say, cut down your cholesterol and fat? It just seems kind of sort of flipped to say that. And, I think some of the sort of older school people may have sort of that older notion that, you shouldn't have this kind of food. Eggs have been considered. I remember, in the 70s and 80s when all of a sudden eggs were the toxin of the time, and now, we're back to eating eggs. So, certainly there's some things missed, and then also, in medicine, cardiology specifically, sometimes the information gets flipped. For instance, a few years ago or within the last year or two, coconut oil was the big thing that the American Heart Association was recommending for heart health, until some new data came out saying that coconut oil was, oh, never mind, it's actually bad for your heart. Don't have coconut oil. What about all those people that were, drinking coconut oil for the last 2 years? So, some of it is just that the information changes over time. And, I think that, I have had patients, I always say vitamins are unnecessary. And then some people will have been telling me, well, my doctor's recommending vitamins. So what is it? Is it, the doctor says it's good or bad? So, there is, just as you're going to have two surgeons recommend two different pieces of information, you may have some doctors who say, have this kind of diet or that kind of diet. But, I think diet in it of itself it's more than just what we eat. It's the how we eat. It's become, sort of this kind of funny activity that has, because of that, we've lost the enjoyment in food. These starvation diets or detox diets where, this notion of cleansing your body of, quote unquote toxins, which is complete nonsense, or, eating on the run or eating all you can eat. That's sort of this whole other idea. Like, why do you need to eat all you can eat? Can't you just eat until you're full? Or why do you have to eat so much? So, I think whatever the doctor recommends is, you need to sort of understand if that's something logical or just, old school, cut down your salt or cut down your cholesterol. But I think it's also just this whole notion of diet has become, it's not just part of your life. It becomes this whole sort of way of
Mm.
of being.
Some of these diets acquire kind of quasi-religious significance in people's lives. But I think a lot of this is also justified by the fact that there are people who have specific needs where a change in diet can radically change their own perception of their health. I mean, there are people who are gluten intolerant or I guess, or have celiac disease. And, for them, obviously a change in diet changes the game entirely. And then that message begins to migrate and get exported to everyone else. And we assume that, okay, we'll all be better off if we stop eating gluten.
Yeah, and gluten is a biggie, and celiac disease is on the rise, and it's a horrible illness when it's not recognized and addressed. And when it is, by cutting out gluten, it is life changing for this population. And there are some people who are quote unquote gluten intolerant, where they get some stomach upset when eating gluten, and they stop eating gluten and they feel better. But that doesn't make gluten this horrible entity. Most people think gluten is a carb. It's not even a carbohydrate, it's a protein. So people translate, the gluten in celiac disease or people who are gluten intolerant to I'm going to cut out gluten and be healthier. And the problem is then you substitute other things which are not necessarily, a lot of the gluten-free food, it tastes so good because they add a lot of oil or rice flour, which isn't necessarily better than wheat. But people have this sort of false notion that they're doing something that's healthful because it's in the health food section of the
Mm.
store.
Is there anything else that you think you would dispense as generic advice to people as far as on some level, it's freeing up some bandwidth around worrying about health and how to modify one's life so as to be as healthy as possible. I mean, the net result of reading your book and talking to you it always comes down to less worry on some level, which attests to your bedside manner. What do you think, as we get to the end of our conversation here, what do you think people should have as a strategy for thinking about these things in their lives? Because everyone if you live any amount of time, especially in the developed world, everyone will find themselves being faced with a kind of wide range of fairly intricate and startling medical decisions and life choices. And your advice is that it can be simpler to navigate that than many people recognize.
Yeah, I mean, I think, obviously diet is a big part of everybody's life. And I think, the problem with these extreme changes in diet is that, people will make as an equivalent eating something to an outcome. And that's usually not the case. For instance, if you have, eat antioxidants, that's another buzzword that you're going to not oxidize and have free radicals and you will not get cancer. And people put, I'm going to drink my anti-cancer shake and not get cancer. And I think there's, a little bit of a false sense of control when people do that. And, I think in general, we are bombarded with health information on a minute to minute basis, all of us, doctors included. So when, we hear this extreme piece of information in the news, it's very easy to panic and, or jump on the bandwagon. So, cell phones cause cancer and, or Ebola is hitting the United States, or, watch out for Zika this summer. These are extreme, terrifying pieces of information. Or, the opposite, coconut oil is going to help you live forever. And, I always recommend that when you hear something that's so extreme and so different from what you're used to doing on a daily basis, that you have to take a step back and think about what that really means in perspective, what it means for your life, and then not lose focus and perspective on what's really important. Basic, eating a balanced diet, getting a flu shot, not texting and driving. These are things that are not going to be headline news. It's not going to pop up on your smartphone as an alert. Oh, by the way, this number of people didn't get the flu because they got the flu shot. This is not going to be headline news, but that's what people are sort of losing sight of and focusing and controlling, trying to control these other aspects of their lives, and, and being less healthy for it. For instance, I'm going to cross the street and do this one text because I know the timing of the car, and I'm not going to get hit by a car because I have control over it. And that, that's a completely false sense of security. And that's, I think, as you said, why we're seeing so many people die in pedestrian car accidents, because people are, not thinking.
Well, so before I let you go, I think we should touch on the vaccine question briefly, because you and I actually did a blog interview a couple of years ago that was entirely focused on that question. So people can read that if they want the full story. But the short form admonition here, what is it, Nina? Do vaccines cause autism, or should we get our children vaccinated?
Vaccines do not cause autism. We should get our children vaccinated, and we should get our children vaccinated on time, meaning that there are designated schedules that are created by the CDC, by the American Academy of Pediatrics, by the American Association of Family Practitioners, that are on schedule for a reason. And that reason is that most of the vaccines don't work after the first or second shot. Even you need that's what these booster shots are. And when kids start falling through the cracks and making up these completely ridiculous, unfounded vaccine schedules, by there are a few doctors who actually promote these, this is why we are seeing these illnesses come back. It's purely related to large populations not getting vaccinated and not getting vaccinated on time. And, there's this idea that, oh, my precious, perfect, clean, pure child doesn't want to be tainted with these toxins. Well, there are more bacteria and viruses during the birth process that a child is exposed to than getting a vaccine. The smallpox vaccine that that all of us got in this, if we were born before 1975, had more immunologic hit than all of the vaccines that kids get from ages 0 to 2. But we didn't have an increase in autism back in the 60s and 70s. So it is not vaccines. That has been showed countless times across multiple countries, hundreds and hundreds of thousands of children getting vaccines, getting multiple vaccines during one visit, has zero impact on development, on growth. The only thing it does is it prevents these illnesses. And these illnesses, some of them were close to being eradicated until people stopped vaccinating their kids.
Yeah, although obviously this is confounded by the fact that, as with any intervention, there's some percentage of people who have a bad reaction. It's possible to have a bad reaction to a vaccine, and it's possible to have a false association between the timing of a vaccine and the discovery that a child has autism, hence the sense that there's still a story to be told about the downside of vaccines.
Right. It's not a cause and effect, though. So, going back to any sort of risk, it's like I tell patients, there's more of a risk of a car accident getting to your surgery than having the surgery itself. So, the vaccine timing is timed with a lot of autism diagnoses. Vaccines are not 0% risk, but the percent risk of real major vaccine injury is, on the billionths of percents. So it's so extremely small and so extremely rare to have a true, negative outcome from a vaccine that, it's still, the risks of the illness far
Mm.
outweigh the risks of the vaccines.
Well, Nina, I'm not sure you saved lives with this conversation, but I expect you saved some worry and some misappropriation of energy and effort here. So hopefully it's benefited many people to hear us discuss these issues. And pretty soon it'll be Monday and you can actually go and save lives in your day job.
Thanks. Well, it was a lot of fun to talk and, raise some good issues. Thank you.
Again, the book is Hype, and I highly recommend people get it. Next time, Nina, when we have another discovery that the private schools in our nation's cities have vaccination rates lower than sub-Saharan Africa, which occasioned our last conversation on the topic, we'll do it again and remind people that children need to be vaccinated.
Excellent. Hopefully not,
Yeah.
but yes,
Okay.
could
Okay.
happen.
If you find the Waking Up podcast valuable, there are many ways you can support it. You can review it on iTunes or Stitcher or wherever you happen to listen to it. You can share it on social media with your friends. You can blog about it or discuss it on your own podcast. Or you can support it directly. And you can do this by subscribing through my website at samharris.org. And there you'll find subscriber-only content, which includes my Ask Me Anything episodes. You'll also get access to advance tickets to my live events, as well as streaming video of some of these events. And you also get to hear the bonus questions from many of these interviews. And then there's the Waking Up course, an app built for iOS and Android, which I'll be releasing soon as a subscription service, which supporters of the podcast get for free. All of these things and more you'll find on my website at samharris.org. Thank you for your support of the show. It's listeners like you that make all of this possible.